Comprehensive Q&A on the surgical management of colon cancer. Welcome to our comprehensive podcast, where today we'll be exploring 100 essential questions and answers on the surgical management of colon cancer. We'll cover anatomy, staging, surgical techniques, adjuvant therapy, complications, special scenarios, and the latest controversies and advances. Pause video when you hear the word answer to attempt answer. Let's dive right in. Anatomy and pathophysiology question. What are the main segments of the colon? Answer. The colon is divided into the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and rectum. Question. What provides blood supply to the right colon? Answer. The right colon is primarily supplied by the superior mesenteric artery, including the iliac-colic, right colic, and middle colic arteries. Question. And the left colon? Answer. The inferior mesenteric artery supplies the left colon, specifically, the left colic, sigmoid, and superior rectal arteries. Question. Could you explain the marginal artery of Drummond? Answer. It's a collateral vessel forming a continuous arcade, connecting the superior and inferior mesenteric arteries. Question. What is Griffith's point and why is it significant? Answer. Griffith's point is a watershed area at the splenic flexure that is susceptible to ischemia due to limited collateral blood flow. Question. What is meant by the critical view in right colectomy? Answer. That refers to the clear identification of the iliac-colic vascular pedicle, the duodenum, and the ureter. Question. What is the most common histological type of colon cancer? Answer. Adenocarcinoma, accounting for about 90% of cases. Question. What is the significance of a serosal tear during colon cancer surgery? Answer. A serosal tear increases the risk of peritoneal tumor seeding. If the tumor is exposed, it is classified as T4A. Question. What is Lynch syndrome? Answer. Lynch syndrome, or hereditary non-polyposis colorectal cancer, is characterized by microsatellite instability and increased colon cancer risk. Question. Could you define FAP? Answer. Familial adenomatous polyposis, FAP, results from mutations in the APC gene and leads to hundreds of polyps and a high risk of cancer. Diagnosis and staging question. What is the gold standard for diagnosing colon cancer? Answer. Colonoscopy with biopsy remains the gold standard. Question. What is the role of CEA in colon cancer? Answer. Carcinoembryonic antigen, CEA, is used for preoperative baseline and recurrence monitoring but isn't diagnostic by itself. Question. Can you summarize the TNM staging system? Answer. Certainly. T1, T4 describe tumor depth, N0, N2 the degree of lymph node involvement, and M0, M1 the presence of metastasis. Question. What does TIS indicate? Answer. TIS stands for carcinoma in situ, or high-grade dysplasia. Question. How is T4 disease defined? Answer. T4A means the tumor penetrates the visceral peritoneum, while T4B indicates invasion of adjacent organs. Question. What is the significance of MSI testing? Answer. MSI, microsatellite instability, testing screens for Lynch syndrome and can predict response to immunotherapy. Question. Why do we test for KRAS and NRAS mutations? Answer. Testing for KRAS and NRAS helps predict resistance to anti-EGFR therapies like cetuximab. Question. When is a CT colonography indicated? Answer. CT colonography serves as an alternative when colonoscopy cannot be completed. Question. What about PET-CT in colon cancer management? Answer. PET-CT is used to detect metastatic disease but not for initial staging of primary tumors. Question. Are lateral pelvic lymph nodes relevant? Answer. No. Those are generally more relevant in rectal cancer, not colon cancer. Surgical management question. What is the standard resection for right colon cancer? Answer. A right hemicolectomy, involving ligation of the iliac-colic, right colic, and sometimes middle colic vessels. Question. And for left colon cancer? Answer. Left hemicolectomy or sigmoidectomy, with ligation of the inferior mesenteric artery. Question. What is the difference between high and low ligation of the IMA? Answer. High ligation is performed at the origin for oncologic reasons, while low ligation is distal to the left colic to optimize anastomotic perfusion. Question. Can you explain the no-touch technique? Answer. It involves early ligation of vascular pedicles before tumor manipulation to minimize dissemination. Question. When should extended right hemicolectomy be performed? Answer. For tumors of the transverse colon, including the territory of the middle colic artery. Question. How do you approach splenic flexure cancers? Answer. With an extended left or right colectomy for adequate margins and lymphadenectomy. Question. What is D3 lymphadenectomy? Answer. It is central vascular ligation of mesenteric vessels. Common practice in Japan. Question. Is laparoscopic resection appropriate for all colon cancer stages? Answer. Yes, provided there is surgical expertise. Outcomes are comparable to open surgery. Question. What is complete mesocolic excision? CME? Answer. CME is a non-block resection with an intact mesentery, aiming to improve oncologic outcomes. Question. When is robotic colectomy preferred? Answer. Comparable to laparoscopy. Robotic surgery is advantageous in a narrow pelvis. Emergency surgery. Question. What is the approach to an obstructing right colon cancer? Answer. Typically, primary resection with anastomosis is preferred. Question. How is left-sided obstruction managed? Answer. Resection plus stoma creation, Hartmann's procedure, or bridge to surgery via stenting. Question. What is a bridge to surgery? Answer. Temporary stenting or diversion to convert an emergency into an elective procedure. Question. How do you manage a perforated colon cancer? Answer. Resection with stoma formation is recommended. Avoid anastomosis in septic cases. Question. What is a blowhole colostomy? Answer. It's a palliative measure to decompress unresectable obstructions. Question. When is subtotal colectomy warranted? Answer. For multiple synchronous tumors, familial polyposis, or megacolon. Adjuvant therapy. Question. When should adjuvant chemotherapy be offered in stage 2? Answer. For high-risk features like T4 lesions, perforation, obstruction, lymphovascular or perineural invasion, poor differentiation, and inadequate lymph node harvest. Question. What's the standard adjuvant chemo for stage 3? Answer. FOLFOX, or oral CAP-OX in select patients. Question. What did the IDEA trial demonstrate? Answer. 3 months of adjuvant chemo is non-inferior to 6 months in low-risk stage 3 cases. Question. What is the role of immunotherapy for MSIH tumors? Answer. Pembrolizumab and nivolumab are first line for metastatic MSIH colon cancer. Question. Is neoadjuvant chemo standard for colon cancer? Answer. No, except in select T4B cases or within clinical trials. Complications. Question. What is the risk of anastomotic leak after colon surgery? Answer. Between 3 to 7%, with higher risk in left-sided or low pelvic anastomosis. Question. What are the warning signs of a leak? Answer. Fever, peritonitis, abnormal drain output, and leukocytosis. Question. How should a leak be managed? Answer. With fasting, antibiotics, and drainage. Surgery is required if the patient is unstable. Question. What's the risk of postoperative ileus? Answer. Occurs in 10 to 30% of cases, usually resolving in several days. Question. What about surgical site infection? SSI? Answer. SSI risk is 5 to 10%, and is higher in open compared to laparoscopic procedures. Question. What is the Clavien-Dindo classification? Answer. It's a grading system for the severity of surgical complications. Question. How likely is ureteral injury in colon surgery? Answer. The risk ranges from 0.5 to 3%, higher in reoperations and advanced tumors. Question. What is the protocol for DVT prophylaxis? Answer. Sequential compression and low molecular weight heparin, extended in high-risk patients. Question. What common ostomy complications might arise? Answer. Retraction, necrosis, stenosis, and prolapse. Question. Can you describe the EROS protocol? Answer. Enhanced recovery after surgery includes early diet advancement, ambulation, and multimodal pain control. Special scenarios. Question. How is stage 4 colon cancer managed? Answer. Resect the primary tumor and metastases if feasible, particularly in the liver or lung. Question. What is CRS and HIPAC? Answer. Cytoreductive surgery with hyperthermic intraperitoneal chemotherapy, used in peritoneal metastases. Question. How is oligometastatic disease managed? Answer. With surgery or stereotactic radiation for limited metastatic lesions. Question. What is meant by metachronous metastasis? Answer. Recurrence of metastases more than 6 months after initial surgery. Question. How high is the risk of local recurrence? Answer. About 5 to 10%, especially with advanced tumors, nodal disease, or close margins. Question. How do you manage synchronous liver metastases? Answer. By considering simultaneous or staged resection. Question. What is conversion therapy? Answer. Using chemotherapy to convert unresectable metastatic disease to a resectable state. Question. Is watch and wait an option for colon cancer? Answer. It's more established in rectal than colon cancer. Question. What is hereditary diffuse gastric cancer syndrome? Answer. ACDH1 mutation disorder also increasing colon cancer risk. Question. Can you explain Peutz-Jeghers syndrome? Answer. It's marked by hamartomatous polyps and an increased cancer risk. Controversies and advances. Question. Is laparoscopic surgery safe for T4 colon tumors? Answer. Yes, provided there's no invasion of adjacent organs. Question. Is sentinel lymph node biopsy standard in colon cancer? Answer. No, unlike in breast cancer or melanoma. Question. What is a liquid biopsy? Answer. Circulating tumor DNA, ctDNA, is monitored for recurrence, as in the Galaxy trial. Question. Is organ preservation an option? Answer. It's still under investigation for colon cancer. Question. What was the outcome of the Taylor trial? Answer. The trial confirmed anti-EGFR benefit in ROS wild-type tumors. Question. What is ctDNA-guided adjuvant therapy? Answer. It's an emerging approach, as explored in the dynamic trial. Question. Does immunotherapy work for MSS tumors? Answer. Generally, efficacy is limited, though research is ongoing. Question. How does robotic compare to laparoscopic surgery? Answer. Surgical outcomes are similar, but robotics has advantages in confined spaces such as the pelvis. Question. Can you discuss natural orifice resection? Answer. It's experimental and not yet standard practice. Question. What is the future of colon cancer surgery? Answer. The future points toward less invasive, more personalized approaches, such as immunotherapy and ctDNA-guided interventions. Thank you for joining us in today's deep dive into the surgical management of colon cancer. We hope these answers will serve as a valuable resource for residents, practitioners, and anyone interested in surgical oncology. Until next time, it's the Everything Surgery Podcast. Dissect the extraordinary.